Okay, good afternoon, everyone. We're going to go ahead and get started. It's 12 o'clock. Welcome to Medicine Grand Rounds. Thank you for those of you attending in person and for those of you online. A couple of announcements before we get started. First, in case you haven't noticed, and I know many of you have, there's a campus block party going on. And I saw many familiar faces out there. If you have time today, please do take some time to enjoy the festivities. Lots of good food and lots of stalls to check out. Upcoming grand rounds next week on the 25th, Dr. John Carruthers will be here. Dr. Carruthers is a gastroenterologist. He's a vice chancellor at UCSD, and he'll be talking to us about his research interest, which is environmental influences in colorectal cancer. We have a very special guest on October the 2nd. The FDA commissioner, Dr. Robert Califf, will be here. He's coming to visit Denver, do a number of things with a number of local entities, and we were able to convince him to come to Grand Rounds for us. So he'll be here for the day. So look forward to seeing you then. Truly is a privilege to have him here. And then October 9th is the Michael John Lecture, and Dr. Adam Shifu will be here from the University of Chicago, a tremendous speaker, and those lectures are always thought-provoking and stimulating. So please mark your calendars accordingly. Today, I have the pleasure of introducing my colleague and friend, Dr. Ann Curtis, who's a fellow chair of medicine at SUNY Buffalo. Dr. Curtis completed her undergraduate studies at Rutgers University, followed by medical school at Columbia. She then completed her internal medicine residency at Presbyterian Hospital in New York City and fellowship at Duke in cardiovascular diseases. Following her training, she was recruited to the University of Florida, where she rose through the ranks to become professor of medicine and director of clinical electrophysiology. As I'm sure she will share, this was at a time when there were very few women in cardiology, let alone very few EP physicians in cardiology, and Ann has truly blazed an incredible path for many of us. In 2010, she was recruited to SUNY Buffalo, named the Charles and Mary Bauer Professor and Chair in the Department of Medicine. She was also then appointed as President and CEO of her own internal medicine physician group practice, which I learned today was actually run by the departments there. So she actually ran the practice plan in the Department of Medicine. Her research focuses on electrophysiology and pacing, including implantable device therapy and clinical trials in atrial fibrillation, and has published more than 350 publications and has done this in journals that you and I will look at and be in awe of. She has too many achievements to sort of summarize here, but I'll give you just a few. She is a distinguished professor of medicine awarded through the State Universities of New York. That is similar to our CU Distinguished Professor title, again, reserved for the very best of our faculty. She is the former president of the Association of Professors of Medicine, which is the chairs group in the country, which is where I first met her. And she's a consistent winner of a number of important awards, including Buffalo's Top Doctors, Castle Connolly's Exceptional Women in Medicine, and most recently was named the Dr. Carolyn McHugh Award for Woman Cardiologist of the Year. We're in for a treat, and so without further ado, Dr. Ann Curtis.
Thank you so much, Vineet, for that kind introduction. And now my job is to get us out of this. Let's see. I was supposed to be able to hit this escape button. Okay, so we're all set? Great. Okay. So, all right, that will work. Great, thank you. Thank you so much for that kind introduction, Vineet. It's a pleasure to be here. I've never actually been to the Anschutz campus here at the University of Colorado. It is most impressive. So it's the buildings have been, are just astounding how much has been growing around here. And then the people I've met have just been so gracious. Everything in my visit has been so run smoothly, and it's been a pleasure meeting so many people. But I'm about to give a talk now that Dr. Chopra heard some of, because as president of the Association of Professors of Medicine at our annual meeting, we get to give a talk about anything of our choosing. And this is what I decided to talk about, because it's something I've had an interest in for many years, research early on up until things I'm doing regularly now. And so I'm going to talk about 6 differences and disparities in the management of cardiac arrhythmias. And, the title is very specifically chosen. Differences are things that are just observed to be not the same between, male and female sexes. Disparities come about when you have differences that are not based on biology, but based on the way we treat people. And those are equally important to know about. So these are my disclosures. And so my objectives over the next 50 minutes are going to be to start with understanding the differences in epidemiology, presentation, and the course of cardiac arrhythmias so that you know the differences based on sex, to recognize sex disparities, and this is where this comes up a lot, is implantable device therapy. So not so much pacemakers, but implantable defibrillators and resynchronization therapy. And then to look at some approaches to addressing disparities in the care of patients with arrhythmias. So I want to start off with a definition. And I call this sex differences because that's the correct terminology. So sex is biologically defined, and it refers to the biological aspects of an individual as determined by their anatomy, its chromosomes, its hormones, its male or female assigned at birth. And so if someone can be transgender or move to another, but the sex in many, we're not going to get into that, but there are determinants based on sex that may not be changeable. Gender is more of a social construct. It's related to behaviors, attributes. It's based on labels of masculinity and femininity. And that's why transgender is the appropriate terminology to use for that. You'll see a lot of people use gender exclusively instead of saying sex, but they do have some differences. So now when I look at mechanisms of sex-based differences, there are a number of them, and just for time's sake, I'm not going to spend a lot of time on them because I'm more interested in talking to you about the clinical aspects of these. But there are lots of things that are responsible for these differences. Sex hormones is an obvious one, but cardiac ion channels are different in men and women. Action potential morphologies, autonomic tone, the hemodynamics, the genetics, and all of those are things that will sort of drive these differences. And I want to start out here. So this is a very specific difference that is seen routinely. And if you look at the bottom two tracings, they're, ECG rhythm strips, women and men, women in the orange. And you can see that they are different, generally speaking, in men and women. So women have a longer action potential duration than men do. And so some of you remember from medical school the different ion channels that contribute to the action potential. A lot of it has to do with a decrease in potassium currents, and potassium currents are what govern repolarization in the heart. And so generally speaking, women have a longer QT interval, and you will see that that is important for a number of different conditions. I wanted to mention just in passing a little bit about genomic tissue expression. I am not an expert in this area. I am not going to go into it in depth, but what I wanted to show you is just briefly some of the work that's been done in this area to try to understand it better. So this one study took 44 human tissue sources to catalog sex differences in gene expression and found that 37% of all genes have some sex-based expression in at least one tissue. And then they're trying to understand that better, looking at sex-based expression of autosomal genes. And that suggests that, that there are these hormonal-related transcription factor regulation that come about in the genes. And these the sex affects gene expression and its genetic regulation across tissues. And again, I'm not going to go into these. Just know that there are people who are very much interested in this area to help us understand the fundamentals of how we see the differences that we see clinically. Now, something that's going to be much more familiar to everybody in this audience is the electrocardiogram. And so if you look at the different parameters of the ECG, PR intervals, P waves, et cetera, there are differences between men and women almost across the board. If you get a large enough group of people, you'll see statistically significant differences, even if you vary by a couple of milliseconds. But the two that I want to point out that are most important, the first one being QRS duration. There is a regular difference in QRS duration, with women having it shorter than men do. And 7 milliseconds is actually quite a lot. And we're going to come back to this when I talk about cardiac resynchronization therapy, because I think it directly impacts the findings that we see here. The second part is I mentioned that the QTC is longer in women, right? And so mean QRS duration in this one study was 418 in women and 406 in men. Well, if you start out with a longer QTC, then anything that affects the QT interval is going to be more frequently expressed in women. So now let's go through the different arrhythmias and what we find. Start out with supraventricular arrhythmias. So I'm mentioning 3 common ones that we see, and these differences are so pronounced that often I could tell you what the sex of a patient is if you tell me what the problem is even before I see them. So starting out, inappropriate sinus tachycardia. So, that's a condition where patients have heart rates that are way higher, and it's a sinus node mechanism, than they should be for the level of activity that patients have. This is much more common in women, and particularly those younger than 40 years. Also, a postural orthostatic tachycardia syndrome is much more common in women. And as a matter of fact, I would have to go back many, many years to think of a male patient that I've seen with this condition anytime recently. The only one I saw was a transgender male. So it really is very, very common. Now, for the 2 kinds of common reentrant tachycardias that we take care of in electrophysiology, AV nodal reentrant tachycardia, which is a reentrant circuit within the AV node itself, much more common in women than men by a 2-to-1 ratio. On the other hand, AV reentrant tachycardia, which is different from AV nodal reentrant tachycardia, because in AV reentrant, generally speaking, the circuit is down the AV node and back up an accessory pathway that might be concealed. That's more common in men in a 2-to-1 ratio. So the differences with AV nodal reentrant tachycardia have something to do with the refractory periods of the pathways there. I won't go into it more than that, but we have some understanding of this, but not perfect. So here's another way of looking. These data really haven't changed much. So AV NRT is AV nodal reentrant tachycardia that I just mentioned as being more common in women. AV reentrant tachycardia, you see there's a lot in men, but in one other study, different from the previous one that I showed, that AVRT was very close. AT stands for atrial tachycardia, and we always see that less often than the other reentrant tachycardias. Now, we see the preceding arrhythmias. Often they get ablated, so patients most of the time don't have an ongoing issue with the reentrant tachycardias, because fortunately we can cure the majority of them. But with atrial fibrillation, we see an awful lot of this, and you all will throughout your careers. So with atrial fibrillation, there's an electrical substrate, there's a structural substrate. As patients' atria enlarge, either for valvular heart disease or other reasons, there's fibrosis. You're going to be more fibrosis in the atria of patients with AFib than those who don't. And there are various kinds of triggers. And so there's a lot that goes into the pathophysiology of atrial fibrillation. But in terms of epidemiology, what we see is that the incidence of atrial fibrillation is lower in women. So throughout, the 50s and 60s in terms of age groups, you'll always see more men than women with atrial fibrillation. However, the prevalence doesn't change with aging, but the difference comes in the older population. Because women have greater longevity, there are more women with AF in the elderly population. The women tend to be older if they have atrial fibrillation, consistently a lower quality of life, and more comorbidities and more symptoms. Now, the CHADS-VASc score, as you know, when we're looking at thromboembolic risk related to atrial fibrillation, includes female sex because women seem to be more prone to having strokes. But it is a modifier for stroke risk, which I can't go into in great detail here. But if you have somebody who you're on the fence about whether or not to anticoagulate because they're already, say, hypertensive, or you're getting into an older age group, what we mean by modifier is the female sex ought to push you closer to doing it. Just a word about pharmacotherapy in women. So the antiarrhythmic drugs generally speaking, impact ion channels because that's how arrhythmias develop. And so if you have drugs that impact ion channels, then you have the chance for proarrhythmia. So some of it is proarrhythmia. There are differences in autonomic tone. With higher body fat, there's a difference in distribution of various antiarrhythmic drugs. There can be differences in the GFR, differences in BMI. So all of these things factor into the safety and the therapeutic margin with drugs such as antiarrhythmics. So in general, if you're looking at the use of any of these drugs in women, the class 1 drugs, which as you know are sodium channel blockers, the class 3 drugs are the potassium channel blockers. There are many drugs that have some aspects of both, but that list there, some of which we don't use very often anymore, but they more often cause torsades de pointes in women. So torsades de pointes is polymorphic ventricular tachycardia related to QT prolongation. Now, the efficacy of antiarrhythmic drugs is comparable in men and women, but women often are prescribed antiarrhythmic drugs less often than men, which, given that they tend to have a lower quality of life with arrhythmias, is really the opposite of what it ought to be. It's a very old study, but nobody's done it since, so I brought this up. But if you look at the incidence of, or the prevalence of torsades de pointes with the use of sotalol by sex, every single age group, that magenta bar is higher than for male, except in the 45 to 54 age range. So we do see more torsades de pointes in women. Catheter ablation is a procedure that can be curative in many patients with atrial fibrillation. Some points that I'd like to make about that. I mentioned already that women have worse quality of life than men do. There can be more adverse effects from antiarrhythmic drugs because of what I've just mentioned previously. Women are less likely to be referred for ablation. They tend to be older at the time of ablation, and that may be a combination of, I told you, they get AFib later, so if you get AFib later, you'll be referred later. But there also may be issues of later referral. And I do believe that if you have somebody who's getting a high burden of AFib, it behooves us to do an ablation or a definitive treatment as soon as possible after they develop it, and not let adverse remodeling of the atria get you to a point where this procedure has much less likelihood of success. The success rates for AFib ablation are comparable in men and women. In some registries, women have had more complications. A lot of times that relates to vascular complications, say in the groins, and that has to do a lot with just a smaller size. All right. So all I'm going to say about supraventricular tachycardias. Now I'm going to move over to arrhythmias, ventricular arrhythmias, and sudden cardiac death. All right, here is a list of many of the ventricular arrhythmias we see in electrophysiology, and it's not important for you guys to know this specifically. I'm pointing out two. These are the ones I think are most relevant for this talk today. And one is that sudden cardiac death is much more common in men than it is in women. And if you think even of celebrities or people that you hear about die suddenly sort of in middle age, most of the time it's men, much less frequently women. I've already told you though that the acquired long QT syndrome, which is acquired because of drug treatment, for example, or electrolyte imbalance, that's more common in women. Now, the Framingham study, which everybody is very well familiar with, and this is some old data, I've got some more contemporary data coming up. They found that the sudden cardiac death risk in women was half of that in men with coronary heart disease. And in patients with heart failure, the rate of sudden cardiac death was increased in women 5-fold. But even with that, it was about a quarter of the risk in men. So the risk is much higher in men for this problem. Here's another way of looking at it, which is one of the ways we say it is that there's a lag in when women are at risk for sudden cardiac death compared to men. And so it's about 10 years. So in other words, the risk of, for example, sudden cardiac death in women who are over the age of 75 is not that far off from a man who's 65 to 74. So we see that. So the risk increases with age, but much less in women than in men. A little bit more contemporary data, look at trends in cardiac death. You can see the dotted lines are for men, sudden and non-sudden death, and in women, the solid lines. And you can see, even though it's been going down gradually for both sexes, it still is higher in men than in women. In survivors of sudden cardiac arrest, and if you look at the underlying diagnosis once they've been resuscitated, in men, overwhelmingly, it's coronary artery disease by 80%. Very low incidence of dilated cardiomyopathy. If you look in women, less than half are found to have coronary disease. Dilated cardiomyopathy is about twice as common in women compared to men. And then there are other conditions. Normal, for example, is higher in women, valvular heart disease, and others. In the Oregon sudden unexpected death study that is recent from 2020, so this is really a whole population being looked at. In their cohort, they had 37% of the group was female. The rates declined for a while and then rebounded. But if you looked at the three timeframes listed here, in men and women, it started at a baseline, went down, and came up again. But pretty much women were about half the rate that men. So even from the older data to the most contemporary, we're seeing that women are about half the rate as men. Here's also Oregon sudden cardiac death incidence rate in men and women, and you can see the differences here, how they dipped and came back up. Now, one of the other issues I think is important to know about is with outcomes of out-of-hospital cardiac arrest, is what the rhythms are when you see these patients. So this is one study looking at over 4,000 patients, of whom 42% were women. And these survivors of out-of-hospital cardiac arrest, the women tended to be older, and they actually did have a higher resuscitation rate. But if you look at the presenting rhythm, you can see that women more often have asystole and pulseless electrical activity, whereas men more often have VT and VF. Now, this may be relevant to what we see when patients have implantable cardioverter defibrillators. It's a hypothesis. But if you have PEA or a systole, having a defibrillator pace you at 60 beats a minute or 40 beats a minute probably won't do a whole lot to help you. Whereas if you have VT or VF and you have a shock delivered from an ICD, it's highly likely to be effective. I did mention the long QT syndrome. The risk of cardiac events in adult women with long QTS, and this is congenital LQTS, is higher in women than in men. The highest rate of events is with LQTS2, which is a potassium channel abnormality. You can see that there are some other findings that we see depending on which subgroup of LQTS that a patient has. And we do know that sex hormones have a direct effect on QT prolongation. This also speaks to the timing of when we see various arrhythmias in patients with LQTS. So you can see long QTS1 and 2, and you can see that by menopausal stage, reproductive, transition, and post, that it goes down with LQTS1 and it goes up with QTS2, which is relevant if you're caring for patients with these problems. Now I'm going to switch over to implantable device therapy and look at sex differences here. So this is, we're talking with the chief residents before about doing work with research with your fellows and residents. Mike Yarnos was one of my cardiology fellows way back when, and we took a look at sex in the ICD trials. And the ones that you see on the left-hand side there are, they're all dated at this point. They were done quite a while ago. Many of them were total mortality as an endpoint, and they were, for the most part, positive, the exception being definite, the one at the bottom, which was solely done in patients with non-ischemic cardiomyopathy. But the real point of showing this is often nobody ever looked at sex or gender. In some cases, the hazard ratios weren't different. In other cases, they were. But there really hasn't been that much attention. Now there is, and I'm going to go into that a little bit later. But these trials tended to have, you can see the percent female, 21%, 8%, very, very much underrepresented. And it would be hard today to get, especially the NIH, to sponsor a trial where you had these kinds of numbers, that kind of imbalance between the sexes. There have been some controversial findings with some of the analyses that have been done of the ICD trials. Here's one that took 5 studies together so they could collect over 900 female patients and looked at the effect of ICD therapy on primary prevention. Here's something that's a little bit alarming, where you have the hazard ratio is right around 1 and the confidence interval straddled 1. So that's concerning. It does raise a possibility that there may be less of a benefit in women than in men. One of the things I like to say is, how are you going to do that study now? There's no way anybody could randomize patients to ICD or not if by the guidelines you say that you're indicated. But it does raise some concerns. But also, when we get to talk about cardiac resynchronization therapy, that's where women do better, and you'll see that. Device implantation rates. So now what we're looking at here are the practice guidelines say that a patient's indicated for an ICD. What's a good example? Somebody with heart failure and an EF of 35% or less, and New York Heart Association class 2 or worse. Those patients are indicated for ICDs for primary prevention. In one registry, Advancent, you could see this had over 26,000 patients. Female gender predicted a lower rate of implantation of any device in any ICD by quite a lot. And these are all indicated patients. Primary prevention of sudden cardiac death, sex differences. This is a study of Medicare patients. And looking at the rates of ICD implantation for primary prevention, you can see that it was about 32 per 1,000 men and almost 9 in women. So men had more than a 3-fold likelihood of getting an ICD for primary prevention compared to women. I think the last statement there is not so important. Yes, there was no difference in survival at 6 months, but I don't think most people are putting in an ICD because you think it's going to work in 6 months and I'm not worried about it later. And as a matter of fact, I'm actually working right now on some data that we presented at the American College of Cardiology earlier this year, and we're working on the manuscript now, showing that for patients who have an ICD implanted for primary prevention, about at least 35% of patients will have appropriate therapy, whether you're male or female, on out to 7 years. So these devices are life-saving. You got to look at a longer time frame. But to see that the same patients who are indicated, women are not getting these, really is, I mean, that's a quality of care issue, really. Now, here, these are data on secondary prevention. Now, think about it. Secondary prevention means that somebody already survived an event. They had a cardiac arrest and they were resuscitated, okay? I don't think anybody in this audience would say this patient does not need an ICD, right? Unless you found some wildly reversible cause. Well, here in this study, the rates of ICD implantation were 102 per 1,000 men. And 38.4 in women. So again, men were much more likely to get ICDs than women were. And in this case, it was significant in terms of reducing mortality relatively soon. And that's because patients who have had a ventricular arrhythmia already, especially in the first few months, are more likely to have recurrent episodes early on. This is actually how guidelines about when you can advise people about driving again come from, is the fact that these come out earlier. Okay, recent registry data, or more recent registry data, looking at rates of device use, there are a lot of disparities. So the Get With the Guidelines program is an American Heart Association program that has had several aspects to it. There's the stroke one, AFib one that I was heavily involved in. But it's a very nice, and there's a heart failure one too. The database has been looked at for the sex and gender distribution of these implantable devices. And so they had over 21,000 patients. So this is multiple hospitals across the country. And these, again, patients eligible for an ICD with an ejection fraction of 35% or less. Women didn't even get told about ICDs at the same rate that men were. Now, the fact that only a quarter of men heard about it isn't very good either. I can't tell you right now We do know that when patients are hospitalized with heart failure and it's an initial hospitalization, that we want to get them on guideline-directed medical therapy, and a decision about whether or not they're appropriate for an ICD has to wait about 90 days so we can see what the response to that therapy is. Does that account for why so many patients didn't get told about something they wouldn't even be eligible for a while or not? I don't know. I don't recall them really specifically talking about that. And ethnic minorities, same thing, that they are also counseled less often. All right, now cardiac resynchronization therapy, I hope most of you know what that is, but patients who have heart failure and heart failure with a reduced ejection fraction, so LVEF is diminished, and they have evidence of conduction system disease or ventricular dyssynchrony. And by that, we usually, most commonly, left bundle branch block. And the wider the QRS, the more dyssynchrony you have. So it's electrical dyssynchrony where the heart doesn't beat in a coordinated fashion. CRT involves putting an LV lead either usually in the coronary branch of the coronary sinus to reach to the left side. You have an RV lead, and by having leads for both ventricles, you can pace them at the same time and resynchronize cardiac conduction. So these devices were first studied a quarter of a century ago. We have class 1 indications for them today. But with looking at sex differences, they actually are quite pronounced. So our center at the University of Florida was one of the phase 1 sites for Miracle, which was one of the first CRT devices that was tested. And so we looked at ventricular reverse remodeling and outcomes in patients who got cardiac resynchronization therapy based on sex. Specifically wanted to know about that with the women. So in this group of patients who were in the trial, if you look at the baseline demographic data, since they were randomized to CRT or not, then of course 50% of the patients got them. But you can see there were some differences in ages and all that. There's a big difference in the percentage of patients who had ischemic heart failure. Now, and we knew that that was the case, and we controlled for that finding in looking at our outcomes. So that's probably the biggest parameter that you see different there. And there was some differences in LVEF too. Okay, so in looking at the time to first heart failure hospitalization or death in men and women, you can see on the left-hand side that in women, it made a massive difference in the time to that first hospitalization or death. Men, it didn't make any difference. And so just as I said, for primary prevention ICDs, we don't take men and say, well, you don't get it, even though you're indicated, because we hope that there's going to be a difference. Is some of this related to the ischemic heart disease? As I said, we controlled for that. But generally speaking, in a general population, if you have non-ischemic, less scar means more likelihood of response, because scar, you can't remodel, you can't make pace better. Sick myocardium, you can if you get it resynchronized. This is a study looking at, really it was different ways of adjusting the programming for CRT, which is really not that important here. But what I'm showing you this for is to look at LV end-systolic volume index, which is an indicator of good remodeling, reverse remodeling of the ventricle. And you can see that women had better remodeling than men did. Their EF went up better, and their quality of life got better. So in terms of CRT therapy itself, women respond better than men. Now, if you look at device usage in patients with heart failure with a reduced ejection fraction, this is actually speaking also to race. And gender. You can see that across the board on the left-hand side, what it's really saying is they work in all comers. So these devices are effective. So it's not like you're talking about groups where it's not. But if you look on the right-hand side, if you look at change in ICD use, you can see that pretty much across the board, white males still get more devices than any other group you can look at. In another study looking at the nationwide inpatient sample, Most ICDs were implanted in men over the age of 65. And this is comparable to what I showed before, which is a much higher utilization. And here I'm just showing too about racial disparities. And fortunately, with Blacks, the rate of implantation has gone up so that it has narrowed the racial disparities quite a lot. But really, we haven't done much with sex disparities. And again, just more evidence about the way this has been shown to be true across different data sets. Now, this is even more recent data. This is something that I worked on with folks from Medtronic, actually, because they were interested in looking at this particular issue. We wanted to see the real world assessment of disparities in the use of guideline-directed defibrillator therapy. You can look at academic institutions or ones that are doing clinical trials, and how those devices are used may be different if you just say, they're market release, they're FDA indications, let's take a look and see what happens. And so we did something called computable phenotyping of the electronic health record. And I couldn't possibly have done this without some computer experts, but they were really, really very helpful. And this is sort of a diagram of how this happens. And what it means is that what we had to do is we had to say, what is the phenotype of the patient who ought to get a device? And so by that, I mean, their New York Heart Association class 2, 3, and some 4s. Their EF is 35% or less. They don't have a cancer that's going to, likely cause mortality within the next year, and a whole bunch of other things like that too. So we said, that's the patient we're looking for. And then you look at the raw electronic health system data, and you try to match up and say, find these patients in there. And the other thing that can be done with this is natural language processing, which means, in an EHR, it's pretty easy that if you, check the box that said the EF is less than 35%, that can get pulled out pretty easily. NLP means I typed it in the note and I can pull it out. So we were able to do both with these data. So this was a project called Glide HF. And the guidelines have clearly advanced since 2012. But when you're looking at data from, say, 2016, you can't look at the 2022 guidelines. You have to go by what they were using at the time that the patients were being cared for. So we translated those guidelines into computable phenotypes, and then we wanted to see what happened across race and sex groups. So there's that same diagram I just showed you. So the healthcare process model is your guidelines. So which patients ought to be getting these devices? The Glide HF analysis we did is that phenotype, and then you get the knowledge to come out and then say classify, predict, understand what's going on, and then hopefully intervene if you found reasons to do so. So the data set, and this is where this is so powerful, 1.54 million patients with a diagnosis of heart failure, cardiomyopathy, or a prior infarct. It was de-identified data from Optum. And so of course they're anonymous. 47 healthcare networks across the US. It was a huge amount of data that we had, including that NLP. So to move to the results, what we saw was that if you look on the left-hand side of ICD, so CRT-D means a cardiac resynchronization defibrillator. So you can use cardiac resynchronization therapy, pacemakers. They're very infrequently used. Most commonly, it's for patients who are elderly and they want to feel better, but they don't necessarily want to have an implantable defibrillator. So ICDs are CRT-D. CRT-D patients were indicated for CRT and an ICD. ICD patients were indicated only for an ICD. So male more than female. And you can see the racial disparities there as well. So now, and even this is not very good in terms of guidelines, because if you're indicated for a defibrillator, you'd hope a lot more than 16.9% of men would get them. So there's a real issue there. And there are racial disparities as well. Another way of saying the similar information, So you can see that, these were newly indicated patients. So first time that they presented with an indication for it. And you can see that it was higher in men, but across the board, there were many indicated patients who weren't getting it. We also looked at the interaction of race and gender, found, not surprisingly, that white men proportionally more often received a device, and the lowest group was actually Asian females. No clue why from this data, but that's what we got. Now, do we just sit back and say, wow, that's really bad. I hope we can do better. I'm going to resolve to do better the next time I go to clinic. Or do you do a process improvement? And so I was involved in the Improve HF study, which was a quality improvement program in the outpatient setting, where we had a number of specialists, not just heart, a lot of heart failure people, but also EP, to look at quality improvement. And so the way the study, this is pure outpatient, it was about 90 different outpatient practices. And so we started out with a chart review, and we call that cohort A. So what was the status at the beginning? How many patients, had, and I'll show you next slide, the different kinds of therapies. So baseline review, we did a process improvement intervention, and that consisted of webinars, of reminders, of information for patients and providers, all different ways that we looked at trying to get people to do better. And then that same cohort A, we looked at 12 months to see if there had been an improvement, and then there was a 24-month chart review. And just to make sure that these practices weren't giving us a cohort of patients and doing something else with the rest of their patients, we had a cohort B, which was entirely different, that we looked at 6 months, and then one at 18 months. Now, this wasn't simply a defibrillator trial. It also had to do with other indicated medical therapies in patients with heart failure. So, ACEs and ARBs, beta blockers, aldosterone antagonists, anticoagulation therapy when that was indicated. And so, so some of these, like the medical therapy, really wasn't very different at baseline by sex. But there was a difference. There was clearly a difference. Well, the difference in anticoagulation therapy, but a difference in the ICD. In CRT, it wasn't different, and maybe people appreciated the fact that women do have such a good response to it. So now what I'm looking at here is what kind of change did we see over time? So as I mentioned, we had all that baseline data. And then we wanted to see what was the absolute improvement. And I highlighted in black the two most important ones for the purpose of this talk, which has to do with the device therapy. But you could see, so for example, on the left-hand column, men baseline, that at baseline for CRT therapy, 38% of them had devices. And for ICD CRT, it was 52. If you look at 24 months, you can see what the improvement was. It increased by 27.5% for men. For women at baseline, for CRTP, as I showed you, they were pretty comparable. For ICDs, they had a lower utilization, but by the time of 24 months, the percentage of women who had these devices was 75%. So it really was effective. So there are ways to do this where you can get things better. So I'm going to wrap up shortly by looking at what can we do to eliminate sex gaps in clinical electrophysiology practice. Because this is something that we looked at with one of my fellows to see what kinds of processes have been done and can be done. So when we think about accounting for sex and gender, and sometimes both terms are appropriate in clinical research, what are the challenges? We don't see stratified analyses accounting for these differences. If you don't have any women in the study, then you're not going to be able to tell if there's a sex difference. So there are opportunities to improve accuracy of data interpretation and develop safer and more targeted therapeutics and combat stereotypes. Now, and one of the important ones actually is government agencies. So policies of the government-based international funding agencies are now demanding that sex and gender be integrated into biomedical research. And so that's true in the United States, Canada, and the European Union. And you can see, I'm not going to read all this, but they have policies and they have key features that say, if you design a study, you've got to include sex. You've got to analyze things that way, and so that we have to see how there are differences. So if you want to address sex disparities, then there are different practice by our clinical practice guidelines. The ways that have been suggested we can do that include stakeholder engagement. There are some in Women Heart, and there are some groups like that that have really looked at how women respond to the idea of getting an ICD. And I think one of the most powerful things is talking to other women who have them. I think that's been very good. So that includes female participation in multiple roles, including in the clinical trial design and conduct. And then we need to acknowledge sex-specific differences in the guidelines. So what can we do? We can stratify research by sex and gender and make sure we got that. The quality improvement initiatives I told you about. I didn't go into some of these, but just in passing to say there is implicit bias in these areas, and so implicit bias training helps. Women in leadership positions in cardiology can help in addressing these issues. Peer support, I mentioned Women Heart, there's Go Red for Heart with the American Heart Association. And shared decision-making is an important component that speaks across the board in what we do in medicine. I'm only throwing this slide up for because somebody's going to say you didn't talk about pregnancy. You're right, I didn't, because that's a whole topic by itself. But we do know that there are changes in pregnancy. Resting heart rates go up. There are more complaints about palpitations. Probably the most important thing, I think it's important to remember that if you have young women who have had SVT, and whether or not in the setting of pregnancy, I always counsel them that if they think about getting pregnant, they are thinking about getting pregnant in the future, see somebody, talk about whether, if they don't want to get ablated at that time or it's not necessary, to have the discussion before they get pregnant, because it's not uncommon that arrhythmias, SVT, increases in pregnancy. And that's the time as electrophysiologists, we don't want to see the patient for the first time. We want to see them when it's much easier to do procedures that might involve fluoro. So I got my last couple of slides, last two slides for me. So I've shown you some of the sex-based differences and the incidence, prevalence, and clinical characteristics of arrhythmias. Outcomes of therapy, for the most part, are the same in men and women. We do know that advanced therapies such as implantable devices and catheter ablation are often not offered to women, or they're offered at a later stage. But we can improve things with performance initiatives and get these gaps narrowed a little bit. And so my final thoughts to you all are that I showed you that 80% of the patients in the ICD and CRT trials were men. What if they were all women? I don't think the guidelines would be the same. Now, so the survival benefit with ICDs might have been more difficult to prove. And I think the indications for CRT would be a little bit more liberal. And we have 130 and above are indicated. But I think one of the reasons why women respond a little bit better is they start off with a shorter QRS. So if you have 130 milliseconds in a woman who would have been 91 to start with, and a man's 98, you've got a bigger absolute difference there. So I think that speaks to some of that. And so we might have had a difference in it, maybe it'd be 120 milliseconds. So we can't forget that these things are important. And so it's a strong argument for inclusiveness in clinical trials across sex and race. And I thank you for your attention.
Dr. Curtis, thank you. Every time I see that, it's sobering data. And you showed a lot of the numbers. I'm just curious if there's ever been any qualitative work with providers and patients to try to explain why these differences may emerge. You mentioned implicit bias. There's also a window period where it seems like there's a catching up that happens a little bit later. Yeah. But I would love to hear if there's any qualitative data in this respect.
Yeah, there really isn't that much out there. I mean, the best you could get to is if a woman turns down a device, what would be the reason? One of the thoughts has been women are often the caretakers. I can't take time off, or I can't be sick. I've got to take care of everybody else. Body image may be part of it as well, because, having a device up here is not as well taken. And I think too many people still think of it as a problem in men. right? And to some extent that's true. But, especially with CRT, there's so many women who get much better that it's well worthwhile to pursue that.
Absolutely. We have a question in the back from Dr. Ernest.
Yeah, thank you for a terrific talk. My question is about patient preference. Is there any data that suggests there's a gender or sex difference in the likelihood of uptake if offered? Does that explain any of this?
Uptake in
If offered, yeah. So there's a difference in like the number of people with an ICD. Is there a difference in the preference for making that step or not that's gender based?
There is to some extent, yeah. And again, it's I think it speaks some to the the preferences of women. The women heart group, that's been one of the best. And what they do is they'll hold programs time to time where women with ICDs talk to other women, and that's a great way to get them to take it up because they see people who look like them.
So thank you very much for highlighting that. And it's always interesting. We have a Center for Women's Health research here, and we talk a lot about these differences. You mentioned something that I actually hadn't heard of before, which is the difference in symptoms related to AFib. Can you tell us a little bit more about that?
Yeah, quality of life does tend to be worse in women. And they do, I actually have always thought that would be a great place for us to do some research because it's hard to get at. So the average heart rate in AFib is a little higher in women. It does tend to be that way. But I don't think that explains all of it. And so I think that is poorly understood. I think there has to be a connection somehow between I'll give you a different example. I mean, there are some patients who know they're in AFib and others don't. There are some people who know they have PVCs and others don't. What is it that drives the awareness of that sensation in the heart? And, I think that may be a gender difference, but the trick is how you study that and get at what the basis for that is. Really what we have now is an observation without a good explanation, unfortunately.
There it is. Thank you so much, Dr. Curtis. The thing that I was wondering about is from that quality improvement project that you did with all of the various heart failure therapies, have you seen that change has persisted over the time since that study was done?
Well, you'd have to go back and check. And no, we haven't done that study because, it's another study to do. I do think there's attrition with any of these kinds of things. The clinic staff changes, the doctors change, whatever it is. And so if you're going to do quality improvement, I think you got to keep checking in. And I think you would know that with any of the studies we do around here. To think that you did intervention and, you're done, you never have to do it again. Wishful thinking, probably, right?
Other questions for Dr. Curtis? Yeah, one more.
Yeah, thank you again. This is changing gears a little bit and more related to your career, but I'm curious, you obviously were such an innovator and a trailblazer in your field. What advice would you give to those of us who are kind of early in training, who are maybe setting out to blaze many of the unblazed trails that still need to be trod in medicine?
That's a big topic. Well, we were discussing some of this before when I met with the chief residents. I think you've got to be proactive. Things are not going to fall in your lap. And so if I look back at many of the studies I did early on, one of the first paper I wrote at Duke when I was a early EP fellow, I walked up to the head of EP and I said, I want to write something. And, and he actually had some data that was just sitting there. And I took it, wrote it up. It was one of my first papers, so you can't wait to be asked. You've got to be proactive about it. And then I say, anytime you have something that's been given to you, then you've got to follow through on it. Because if you do good work, people will ask you to do more. If you can't count on you, we're not going to do it. But figure out what your passion is, find ways to do it, find mentors, and be you got to be your own best advocate. You know, I would go to the Medtronic reps or, you know, the Boston side, all of those people. Is there any research I can do? They would offer to bring me to, you know, and lots of doctors did this, you know, go to their headquarters and meet with people there and look and see what things I could get involved in. Because a lot of times, you know, if you start off with some of the lower level, you know, I mean, game changers are things that change the way the guidelines are, right? It's nice to get those studies. You don't tend to get them early on, but if you do, you know, do get involved, if they know who you are, if you speak up, then more opportunities come. I think that's probably, yeah, mentorship and being your own best advocate are, I think, the most important things.
And thank you so much. A lovely presentation.